Hi, I'm Dr. James Amos. I'm a staff psychiatrist at University Hospital in Iowa City, Iowa. And this is yet another Dirty Dozen presentation. This one happens to be about catatonia, and I've done a couple of these previously, but this one is inspired by a presentation done by a colleague of mine at a departmental grand rounds. Dr. James Beakley gave an excellent presentation about catatonia, which I unfortunately was unable to attend because I was on vacation. But he was kind enough to allow me to use material from some of his PowerPoint slides, and the presentation that I'll be keeping track of here with my 12 slides will be available on the practicalpsychosomaticist.com, which is the blog site where I'll have a video of catatonic signs and symptoms as well, which probably are a better way to show you what this syndrome looks like in patients and a very good actor. The slides I'll follow along from here, and the first slide is some basics about catatonia. A rough and ready definition is that it's a complex neuropsychiatric syndrome often marked by bizarre motor signs, which can range from immobility to purposeless agitation, and can result from either medical or psychiatric causes, and that's important to remember. It can lead to dehydration, contractures, deep venous thromboses, and pulmonary emboli, and can result in death if it's not recognized quickly. Mortality rates can be high when catatonia is not treated promptly. The rates of catatonia in patients tends to be higher in mood disorders, psychiatrically speaking, about 37% occurrence rate. Psychotic disorders, it's about 28%. And in medical causes, it's about 20%. And there's a historical overview that you guys can look at on your own. The next slide is about catatonia according to classification manuals, specifically the DSM-5 and Alan Francis's Essentials of Psychiatric Diagnosis. The DSM-5 calls catatonia a neuropsychiatric syndrome which can occur in the context of several psychiatric and medical conditions. It's no longer exclusively a subtype of schizophrenia. It can be coded as a catatonia associated with another mental disorder. There are various specifiers about this, usually mood and psychotic disorders. Catatonia due to another medical condition, and there's an unspecified catatonia category as well. It's defined by 3 or more of 12 psychomotor features, which are variable in actual presentation and can vary from stupor to marked agitation. The presentation is variable enough that that's probably one major reason why it's so often missed or mischaracterized as something else. Dr. Francis notes that it can be coded as catatonic disorder due to another medical condition. He gives a nice description of a diagnostic prototype describing motor abnormalities, which can include waxy flexibility and prolonged mute and immobile states. Now, catatonia is not coded if it occurs exclusively during delirium or neuroleptic malignant syndrome, which is considered by many to be a drug-induced form of catatonia. However, I have seen clinically in the hospital cases in which it looks like people are varying from a delirium-like presentation to a catatonic-like presentation. So it's good to keep an open mind. The DSM-5 catatonic features, of which 3 must be present, are listed on the next slide. I'm not going to go through all of them. The most common ones are stupor, mutism, and some posturing. Negativism is not that uncommon. There can be mannerisms or stereotypies, agitation or echolalia may also be present. There is a pretty nice paper on prototypes, which can include the distant mute, the waxy stiff, the broken record, and the stubborn grouch. This is a paper by Azam, the reference to which I've included on the slide. The distant mute is sort of self-explanatory, and this patient is usually mute and immobile. The waxy stiff, this will be a person who can exhibit what some people call the pillow sign and hold postures for a very long time, such as holding the head off the pillow in the bed for prolonged periods of time. The broken record, of course, refers to echopraxia and repeating meaningless phrases over and over again, which is called perviduration. And then there's the stubborn grouch, which can be missed, and it's mainly the presentation of negativism. Proposed variants include, among others, the neuroleptic malignant syndrome. That's a drug-induced form of catatonia, and you want to avoid antipsychotics in most cases of catatonia in which you really don't understand the cause of the catatonia as yet. There's also an NMDA receptor antibody encephalitis condition which can produce catatonic-like syndromes which are indistinguishable from those that are caused by psychiatric syndromes, and those can be responsive to electroconvulsive therapy. Catatonic pathophysiology is not well understood. There can be familial clustering, which can indicate a genetic component. Certain neurotransmitter systems are involved based on the patient's response to certain challenge tests, like the lorazepam challenge test. That would be gamma-aminobutyric acid, or GABA. And dopamine systems are also involved, since you can make them worse by giving antipsychotics. The different syndromes medically in which catatonia can be seen is epilepsy and certain types of endocrine and immune conditions, and there are very nice summaries of these in the papers by Andrew Francis, Catatonia Diagnosis, Classification, and Treatment, as well as another paper, Idiopathogenesis of Catatonia, Generalizations and Working Hypothesis. This is a very nice and interesting paper that you can read on your own. Associated medical and psychiatric causes in mimics are many, which is another reason why it's probably often missed. It can be caused by liver and kidney failure, viral encephalitides, complex partial seizure disorder. Psychiatric mimics include selective mutism and dissociative states, as well as affective psychosis and schizophrenia. Akinetic mutism, which you could probably understand as another name for catatonia, can mimic catatonic-like states, and there's a specific sort of interesting test for this called the telephone effect, which I'll discuss next. Catatonia assessment is the next slide, and it can be done by rating scales. There are probably a half a dozen rating scales. The one that's best known is the Bush-Francis Catatonia rating scale, and the standard exam for that is on this particular slide, and you can read that, but it starts off by observing the patient while trying not to engage the patient in conversation. You want to try scratching your head in an exaggerated manner to elicit echopraxia, and you can examine for cogwheel rigidity while instructing the patient to keep your arm loose. You should also do a chart review for oral intake, check vitals, incident reports on bizarre behavior, and attempt to observe the patient indirectly several times a day if at all possible. The assessment includes challenge tests, which are interesting, and maybe there are different challenge tests that identify different populations. For example, akinetic mutism, which I mentioned before, in which the telephone effect is used. There's an interesting paper about this that's a classic by C. Miller Fisher. He's a neurologist, not a psychiatrist, by the way, and it identifies probably stimulus-bound behaviors in brain-injured patients mostly, although I have used the telephone effect in patients with affective psychoses, and it seemed to work. So the telephone effect works especially for patients who are mute and immobile. If they won't talk to you, you put a telephone next to their ear, you walk out of the room, and you call them from outside the room, and sometimes those patients will answer questions then. They won't be conversational necessarily, and not always spontaneous. but it seems to be effective. The usual challenge test that we often implement for catatonia is the IV benzodiazepine challenge test, and we often use lorazepam for that, a couple of milligrams intravenously, and in some cases within a few minutes the patient will obviously be more spontaneous and talk more normally, and it in some cases looks like a miracle. It may not be sustained, and you may have to look for another way to induce a sustained remission from catatonia. After these patients wake up, they sometimes recall feeling very, very anxious and tense while they were in that catatonic state, and may also describe being very scared to move in case something bad or catastrophic would happen. Catatonia treatment include benzodiazepines mainly and electroconvulsive therapy. ECT is considered the gold standard. 60 to 80% of people will rapidly improve with an IV lorazepam challenge test. If the challenge is successful, you can continue it for a couple of days, but if there's not a sustained response to benzodiazepines, you probably want to consider whether or not you've got an adequate medical or psychiatric explanation, and then consider the next step, which would be ECT. ECT tends to be effective regardless of whether the cause is medical or psychiatric. The summary slide is the last slide, and it just reiterates that clarifying the underlying cause of catatonia is essential. Catatonia may be one final common pathway for many kinds of pathology, regardless of whether they are caused by medical or psychiatric etiologies. Catatonic treatments, whether they're benzodiazepines and in ECT, have a favorable benefit-risk ratio and should be used promptly. Learning how to assess catatonia is critical, and keeping it in mind whenever faced with bizarre presentations is important. An assessment for catatonia should be a regular part of catatonia or a regular part of psychiatric diagnostic evaluations and research. And once again, I want to acknowledge Dr. James Beagley's excellent presentation as an inspiration for this short summary of catatonia. Thanks very much for listening.